Hi.
Hello, doctor.
Hi. Looks like we are all.
Hi, how are you?
Very well, thank you.
Good.
All sharp ladies are looking very sharp.
Thank you.
Thank you, and you too, you're looking very smart.
So we just give it another 12 minutes and just for attendees to join in and the other panelists, and then we'll kickstart.
Yeah.
Greetings to the attendees. We're already online. Thank you for joining us.
God, there are people online.
They can start posting questions.
Okay, we'll just send a general chat asking people to start posting questions if they wish. So to the attendees already on the line, please, you can start posting your question if you wish using the Q&A pane on the control panel.
I don't know what is wrong with my screen. Or please, I've tried to use the, what do you call that thing?
The background, the virtual background?
The background, but it's asking me for a virtual whatever, and I don't have it. So I don't even know how to remove it again. Because
that's
it's not,
fine, you're right, ma'am.
It's not giving me a good video, if you notice.
Yes, you can remove your background. You don't have to have a virtual background.
Hmm.
It is Gimbat, you're looking very nice.
I am, but I'm not. I don't know why it's not giving me what I want. Seriously.
Are you able to go into your settings?
That's the setting that I'm even looking for. I should have used my phone. I wanted to use the laptop. But
it might be in your, when you actually log into Zoom. That's where, before you join the meeting.
Before I joined, I've been fiddling with it. Let me call Farida again so that she does it for me in the next 5 minutes. Oh God, as if I'm back to secondary school.
You'll be fine, Mrs. Giva, you'll be fine. Good afternoon, Inusa.
Hi, Kofi. You should face the light or back the light because I'm not seeing you clearly.
Yeah, I know. When I
Do something about it, please.
the
I need
light
to see you.
the light is right on my head, and I can't
I
change.
just so
Okay,
do a bit of 180 change and see what I do. How are you? I like the slides.
Yeah,
Yeah.
it's
So Jummai, you are now Hajia.
I'm not
See,
Hajia.
I can see
Hajia.
that. Hey.
Hajia is only when you go to Hajj. Forget all this.
How are you?
I'm fine. I'm fine. Very much so.
So I didn't see my
Someone
I didn't see
saw.
my picture with Farid, you know. I'm disappointed.
I'm telling you, I
Exactly.
tried to look for all my pictures. I tried to look for all my. I tried to look for all my pictures, but I just don't know because there were too many,
Well done.
and that's
So
why I only shared the one that we had at Scotland House.
it's very good, very good. And Nadine, do you have do you want me to call Muhammad?
Yes, please. Yes, please.
Okay. So by the way, I just told the governor's wife that we are presenting. Then I just tell governor's wife. I forgot to tell her before.
So we're just going to wait for 5 more minutes, and at 3 p.m. on the dot, we will start.
So you are talking about this platform. I haven't been able to make the platform my background.
It's all right. We like the hospital setting.
Okay, that's good. Thank you. Yes. I'm shuttling between clinic and patient, and I'm on call on the ward. Today is my first day back at work, and you know, everybody think that you must do everything for them.
Oh, me, I thought universally is Independence Day.
Hey, when we lost funding from Nigeria, you think you should be celebrating the UK?
Yes, I thought everybody is celebrating Independence Day today, the worldwide. Good afternoon, sir.
Good afternoon,
sir. Yeah, how are you, sir?
I'm back on.
Is that Farida?
Farida, come and say hello to Dr. Inusa. Yeah, the guy again. She's very shy.
Okay, Nadine, go on. You are in charge.
Good afternoon. We've not started. So.
Yes, good. And Nadine, go on.
We have 3 more minutes. We already have some attendees on the line. I posted earlier that you can start putting in questions, but please go ahead, panelists. The floor is all yours until 3 p.m.
Rotimi, what didn't happen? Did you register? Okay, so we're on.
Good afternoon, Dr. Makusidi.
We can see you and we can hear you.
Good afternoon, and once again, happy Independence Day.
Thank you very much,
Though I say we are 60, but we are not yet mature. You're welcome.
We are getting there. Hopefully, we'll have gone a step further after this session.
Okay, hopefully. Thank you.
So 2 more minutes, just so that we stick to the time that we had set for the session, and then we'll start.
No? Okay, we are on Zoom meeting. Yes. Who is this man shouting?
Almost there, 1 more minute to go, and we should be able to start. Awesome. It is 3 p.m. on the dot, and I think we can kickstart. Hello, hello. I hope you can all hear me. So good afternoon, everyone, and welcome to this session of the Platform Nigeria. I am Nadine Lawal, and I will be your host this afternoon. So just before we get started, I would like to go through a few housekeeping items just so that you can participate better in this session. So you're listening through the default audio system of your device. So if you would, you can adjust the volume to your preference and you will be able to hear better. So all the participants, with the exception of the panelists, will be muted throughout the entire session. However, you can post your comments in the chat room on your control panel. So post your comment there if you wish. We would like this session to be as interactive as possible, and all the participants are encouraged, invited to send in their questions through the Q&A pane on your control panel. So I repeat, if you have questions, please send them using the question and answer icon. It's at the bottom on your control panel. Only the questions sent through the Q&A pane would be addressed to the panelists. You can send questions all through the session from the beginning to the end. We would collect them and we will push them to the panelists. The session is yours. So joining us today to discuss this very important topic of breaking down the stigma around disabilities and special needs in our country today are 5 experts in their craft. I will start with Mrs. Aminat Gimbat. She is the mother of a young adult son with special needs. She's a strong and passionate advocate for the rights of people with disabilities. Under her leadership, the Farid Center, which she runs, has carved a niche in creating awareness through seminars, as well as therapy sessions to support parents and also caregivers, and to dispel the negative cultural beliefs about people with special needs. Thank you very much, Mrs. Gimbat, for joining us today.
Thank you for having me.
Thank you, ma'am. Our next panelist is Dr. Kofi Anie. He's a consultant psychologist with extensive clinical experience in supporting children, young people, families, and also adults living with sickle cell disorders. He is also the co-organizer of the Family Resilience Program. It's a program which provides the opportunity for families to come together and build capacity to recover quickly from all the various difficulties associated with the sickle cell anemia disorder. Dr. Anie, it is a pleasure to have you with us today.
Thank you, and happy Independence Day to all.
Thank you very much, sir. Our third panelist is Dr. Inyang Takon. She's a consultant pediatrician, and she specializes in and has immense clinical experience in the assessment and management of children with developmental disorders and also neuropsychiatric disorders. She has this vision for Nigeria, which is to improve early recognition, the assessment, and also the intervention for children with developmental disorders. Thank you very much, Dr. Takon, for making time out to join us today.
Thank you, Nadine, and happy independence to everyone.
Thank you very much. We can see your green outfits. So our next panelist is Professor Baba Inusa. Dr. Inusa is a renowned pediatrician. He has interest in global hematology, sickle cell disease, and thalassemia. And then he carries out a lot of research activities that are focused on sickle cell disease complications, newborn screening, and renal disorders, and also health-related quality of life. Dr. Inusa, thank you and welcome to the platform breakout today.
Thank you, Nadine, and it is a pleasure to have the opportunity to share with my people in Nigeria. Thank you.
Thank you, sir. And our final panelist is the Honorable Commissioner for Health for Niger State, Dr. Muhammad Makusidi. He's an ENT doctor with over a decade experience. He's a passionate educator, and he has also presented at several conferences on issues such as rhinosinusitis, hearing loss in patients with sickle cell disease, and hypertension. Dr. Makusidi, thank you so much for joining us. We know you're very busy and we do not take it for granted.
Yeah, thank you. Good day and happy independence to everybody.
Thank you very much. Same to you, sir. So, Mrs. Gimbat, I would like to kickstart our session with you today. You are the mother of a son with cerebral palsy. Please, could you give us a glimpse into your journey as a mother of a child with special needs in Nigeria?
Okay, thank you very much. I am a mother of a boy. He is 18. He will be 19 on the 29th of October. He was born here in Nigeria, in Mina. And he was born a normal delivery. He was born 4.2, so he was a big baby. But I had a bit of prolonged labor. He isn't my first, he is my third child. But I had a bit of prolonged labor and some challenges while giving birth to him. When I gave birth to him, I didn't hear him cry. I still remember that. You know, some things you never ever forget as a parent. So I didn't hear him cry, but I know I kept asking. He didn't cry, but the doctor said, no, he cried, but I just didn't hear. So I should take care of myself because I had a tear and it was quite a difficult birth, actually. I gave birth to him at 1:27 by 3 a.m., 1:27 a.m. By 3 a.m., we were discharged. And in the morning, I said, okay, fine, because I was used to giving birth, seeing the child being looked after by a pediatrician. Dr. Fashina actually introduced me to that kind of system. So I said, okay, fine, let me take him to Dr. Kwati so that at least they look him over. Unfortunately, I didn't go, but my younger sisters took him. Then they came back home and I thought, oh, why are you home? Oh, you're already home so early. They said, no, he's on admission. And I was like, for what? They said he was breathing abnormally. And that was the beginning of it all. He was breathing. He had stridor, and we stayed a week there. From there, we went to National Hospital in Abuja. From there, I know a nurse whispered in my ears, do you know anyone outside this country? And I was like, why are you asking? She said, oh, if you know anyone outside this country, please take your son there. I was so scared at that stage, but that was how the big journey began. And I took him to UK. He was found to have developed, he had undeveloped epiglottis and all that. So he started NG tube feeding. Before then, we were feeding him okay, normally. So that means he had a lot of fluid going down his lungs, and that did a lot of damage. My son's problem started gradually. But in that period that we're trying to look for intervention, I met a lot of people. I met a lot of doctors. The foremost was Dr. Inusa, who we'll never forget, but he, so he took us round, we were in and out. But you see, the process had already been set in, so he's a CP child, the long and short of it. And in the process of looking for intervention for him, we went to Enugu. We stayed there for like 2 years. From there, we went to UK, stayed for like 2.5 years, all in that process, trying to look for intervention for him. I remember all that time, anytime we were shifting from one place to another, we weren't together as a family. I had to leave my other kids back home because they were in school and all that. My husband, I had to leave him here. So finally, I think I took the words of Dr. Ebibo. She is the proprietress of Therapeutic Daycare Center in Enugu. That was where we were. And she said, go back home, Mrs. Gimbat, go and hold on to your family and establish somewhere, Farid-centered. I will never forget those words. And so that at least you can help Farid at the same time you help other children. And that's how we took the decision to come back home to Nina, Niger State. And we started a center for children who will be friends with Farid and be with him. And then we can see how we can help those others to get early intervention that we didn't get. And then that will enable us to help them at the same time. So we run a center now, and we named the center after Farid, and it's under the aegis of the Farid Foundation. And we offer a lot of services. Foremost is counseling. I counsel a lot of parents. They tell me a lot of stories about what has happened to them. So you see, it's something that I know that in the bid to not to keep Farid at home just by himself, which he didn't like. Anytime you leave him for 1 hour, 2 hours without even playing with him, he doesn't like it. So this now enabled him to have other children around him and, more physical interaction, and other children who at the same time they come and they are very happy to interact and to engage in doing activities which hitherto people don't think that it's possible for them to really have. And that's the genesis of what happened to us with Farid in a nutshell. I wouldn't want to go into the long of it.
No problem. Thank you so much, Mrs. Gimbat. So we'll move on to the next panelist also to get their perspective on this topic, and then we will come back to you with questions. Thank you so very much to the attendees. We can see questions coming in already, and we will take them as soon as every single panelist has given us their perspective on our topic for today. Dr. Anie, you work with patients and family who face one form of stigma or the other. Please tell us more about the whole concept of stigma.
So, as you can hear from the story, disability or illness does come with a lot of stigma. This is across every society, be it in Nigeria, be it in other African countries like Ghana, where I come from, be it in the UK or in the States. It's a very big problem. But stigma by definition is something that is either shame with disgrace. So it tends to lead from prejudice related to something that is socially unacceptable. I mean, the definition of stigma actually came originally from the Greeks, whereby they talked about people being sort of marked so that they are distinct in terms of whether it's a disability or something that is not acceptable within a society. And what you tend to find is also that people are ostracized or they are treated badly because of some feature. The individual themselves has little or low control, and this can be physical as well as mental health features. So sometimes if you look at it, when you see somebody who is mentally ill, for example, people either tend to tease them or, they don't show any respect for their dignity. And then also if we see people who are physically disabled or physically challenged, we tend to do the same. So as you can see, anything that makes somebody stand out of the normal society, so to speak, looks different. And these undesirable visual disabilities are within cultures by definition or within a society as well. Then let's look at how stigma has an impact on, let's say, the family, the society, and culture. So we tend to have family and society's attitudes to disability. This includes certain myths and misconceptions. And as you can see from the example that we've seen from the young man's Farid's case, it is something that people would have certain beliefs about, which are not necessarily correct. And we tend to have these supernatural beliefs, for example, things like witchcraft. We might also say that somebody has, a disability because of some divine retribution, some sort of punishment, something that maybe the family were supposed to do, or something that the family actually did. And this within a cultural context is usually very challenging for, let's say, the individual as well as their own family that they live with. And then we have all these practices, which I think sometimes is because of these cultural and religious beliefs, some of these issues that will lead people to say, let me go to a traditional healer. Because if somebody is supposed to have an illness or certain features, some disability, and they say it's because the person is a witch or a wizard or something like that, or some witch or wizard has cast a spell, then you are going to go the traditional way to look for solutions. And then there's also one important area, which is non-acceptance. From my own experience, especially when it comes to certain conditions, I work a lot with people with sickle cell disease and their families. Because it's a kind of like a blood disorder, you'd find that the blame is on the mother simply because the mother is the person who bears the child. And that applies across the board for other conditions and other disabilities as well. Because the mother is childbearing, anything that is non-acceptable, you see that in mental illness as well as physical conditions, anything that is non-accepted by the society or the family, the blame is on the mother. And sometimes we don't look at it from the point of view that in some cases it could be genetic, in some cases it's just by the way that child was born. And then let's see how it actually impacts on the individual. So in terms of what we might call self-stigma, a classic statement that somebody would say is that I'm ashamed of myself because I have certain features as a result of our disability, for which people would ostracize me or people would shun me from their society. But how are they supposed to cope with it? So if you look at it, from that individual's point of view, what they need to do is to not blame themselves. So don't let stigma create self-doubt and shame. And also don't equate yourself with your illness. And again, the example for sickle cell is that we call them sicklers. So in essence, what we are saying is that anybody with sickle cell disease is a sickler, and then we identify them by that label instead of saying that such and such a person has sickle cell disease. And then another thing that is important not to do is not to isolate yourself. You have to try as much as possible not to be lonely. Try as much as possible that you go through whatever you can with the support of family and others. And also, what we've seen is that support groups are very important in terms of helping individuals as well as families. And when we talked about the family resilience, that is one of those areas that is quite important. And then the final area that is important, again, is to seek professional help. I'm a psychologist by training and background, and that is where people like myself come in. You have to deal with the emotional aspects of what people are handling on a day-to-day basis, things like fear, things like anxiety, things like depression, for which you would need some sort of professional help. So in conclusion, it is a way of just saying that we need to cope with ourselves if we find that we have a certain disability, and in terms of the stigma, trying to find ways in which we can get support to do that.
Thank you very much, Dr. Anie. You made some very interesting points there. And we have some questions already. So quickly, let's move to Dr. Takon. So Doctor, you've trained as a medical doctor in Nigeria before moving to the United Kingdom. And you've also conducted some research studies in local governments in Lagos and in Ibadan. Please, could you shed more light on what exactly is a disability, what is a special need person, and then what was your experience in the field? What was it like as a medical professional?
Well, thank you, Nadine. I just want to say that I've lived, I had most of my background training in Nigeria. I actually did my medical school in University of Ibadan. And then after that, did my pediatric training in the Lagos University Teaching Hospital. So I got qualified actually to be a consultant in Nigeria before coming out. And one of the things that drove me to come out to the UK was actually, I was interested in neurology before, and I was seeing children with neurological disorders. But I saw that a lot of the children that I was seeing actually needed more than that, and we were not able to do anything within the scope where I was. So we were more focused on treating acute illnesses in the hospital. We were very good with managing children when they came in acutely sick. But after they left the hospital, we didn't know what happened to them. And many of those children went on to develop disability. So that was what drove me to come out to the UK, to come and get the experience and actually be better at supporting children, which I'm going to talk about. So just going back to the question of disability. So disability is any condition that can affect areas of functioning. So it's a universal thing. And it's just to let all of us know that any of us can be subject to having a disability at any time. So it's a universal experience. It's not for a set of people. Anyone who has an illness that has made you limited in any of these areas I've listed could end up having a disability. If you're limited physically, limited by your speech and language, your behavior gets affected, and it impacts on you being able to access society, do your usual day-to-day things. So as adults, we can all be subject to disability. It's not a respecter of persons, which is the reason why it's very important that we get this right, that even though we're all walking about, everybody is at risk, and there's a need to make sure that the services are there. So any of these areas that impacts anyone for a long period of time and limits you being able to access everything that you do on a day-to-day basis is what we call disability. Just in a nutshell, to explain that's the terminology. Then when we come to special needs, so we know that children have to access education and access things. Now, if your disability impacts on you so that you cannot access that learning in the same way that your peers or other children without those problems can access, then you have special needs. It means that for you to be able to access the same level of education that other people are accessing, you need extra help. And think about a child with a speech problem who wants to communicate, but without the adequate communication aids, without the therapies, without the medium to make that child understand what is happening, then that child will have limitations. So that child just needs that bridge to be able to access that learning and access the same activities. And it's brilliant what Mrs. Gimbat has done, because one of the things she said, which I picked up on, was that the Farid centers help children to be able to do activities which people thought they were not able to do before. And that's what we want. We want children, irrespective of your disability, you should be able to do that. You should be able to interact with your other people. So that's what we refer to as special needs, knowing that these children, without that support, they cannot access the same level of education and learning in the school. Now, I've put there that most causes of disability in Nigeria are actually preventable. And we're actually a very lucky country, because where I work in the UK, most of the causes are non-preventable. There are lots of genetic causes. There are lots of things that people can't solve the problems about. So we have children with genetic disorders, which we cannot do anything about. But if we think about Nigeria, think about the birth asphyxia, think about children who have trauma at birth, think about infections, think about severe malaria. All those things cause disability in children in Nigeria, but think about it, they are all preventable. So if we had a good structure where we had services that are helping to prevent those children suffering these things or being treated immediately they are affected, we will limit disability. So I've just put that there, that as a country, we're actually blessed that we don't have a burden of the high genetic problems that we have in the part where I work, where we know that the child has a genetic disorder and you cannot do anything about it, but you can actually improve the quality of life of those children. So next slide, please, Nadine. Sorry. Did you have
Please go ahead, Doctor.
Yeah, okay.
Please go ahead. Once we finish the perspective, we will take the questions.
Okay, so regarding my experience in Nigeria, one of the things I said when I did my pediatric training, I spent a lot of time in the hospital, and I did a lot of hospital acute medicine. And one of the things was that we were seeing the same children coming in with illnesses, and we would treat them in the hospital, send them away. But when we were following them up in clinic, there were many children who had disorders, behavioral disorders, ADHD, autism, and things, which we saw later, and we did not know what to do. So most times we would just talk to the parents and say, okay, or we'll give them some multivit and things to go home with. That wasn't doing anything. We were not trained that way. So we did not know what to do. So most of those children went away. And when I look back now, I see that there are many of those children that we could have helped. If I had the training I had now, I would have helped a lot more children then. That is why I'm passionate about saying that we need to work towards improving that, because when we train professionals, including health professionals, to identify, to be able to put in the structures and the treatment strategies early, we can reduce the impact and we can give children a better quality of life. So training, there's poor awareness. Even in the hospitals, you find that children come to the hospital, most people don't know what to do. So the children are not given the necessary care they need. So in terms of how can we help, I've put training, because this is one thing I'm passionate about, is that if there's anything we take away, especially from the talk that Dr. Anie has given and Mrs. Gimbat has spoken about, training is very essential. Improving community awareness, improving teaching in schools, improving teaching amongst the health professionals across all levels. Unfortunately, we have a system where everything is in the tertiary hospital. So everything is like that in the big teaching hospitals or nothing. We need to skill up our primary healthcare centers, all the levels of hospitals. We need to skill up all the baseline structure so that everybody there is aware of how do I quickly identify a child with disability? What can I do to help? Family members, Dr. Anie has given a brilliant description of his work. And early detection. So when children are discharged, there needs to be a way of monitoring them so that you know when they begin to show those signs of being developmental difficulties. What can we do? Early intervention helps. We have lots of people we can retrain. We don't have enough therapists in Nigeria. Neither do we have enough therapists here. So there's this notion that maybe we have a lot here. No, we have the same problem here. But what we do and what the therapists are good at doing is training sometimes the parents, training the teachers, training other people that can deliver that therapy to that child. So we have shortage here. Many times the parents can't access the therapist directly, but they have that training to know what to do until they see the therapist. So we have, and this is something that we should look into, train people, unemployed youths, train other people to be able to deliver these therapy sessions, community members. And then we can look at using technology to explore delivering sessions. There's nothing stopping an experienced therapist being able to train people in Nigeria, being able to work in partnership with people to actually deliver therapeutic care. So you can have speech and language therapists training other people, training the parents on what to do. Because in Nigeria, we don't have enough. I remember one hospital having just one therapist to the whole center. So we need to think about this. And I think other things will come in the question and answer session, but I believe that I've been able, hopefully, being able to say the bit I need to say.
Thank you so much, Dr. Takon. And then picking on your second line about early detection. So Dr. Inusa, you have conducted extensive research and work with sickle cell patients in Nigeria and the UK. So would you classify sickle cell disorder as a disability? And then what role does stigma play in the life of your patients?
Thank you, Nadine. I think it is very helpful to listen to what the three speakers actually have addressed. And whether sickle cell is a disability, I think is a very difficult question that I actually get a lot from my patients. There are reasons why sickle cell disease could fall into the category of a disability. But in terms of as a condition, I think it's important to have a more positive perspective. And obviously, if they have any of these complications, which are very common complications, it could lead to disability. And I think one of those key areas is stroke. So about 11% of sickle cell anemia patients by the age of 18, if they've never had a preventive therapy, they could have a stroke. And stroke in sickle cell disease is about 250 to 300 times more common compared to children that do not have sickle cell disease. And this obviously could be one of the reasons. But apart from that, there's also what damage to the brain, which is called silent cerebral infarct lesion. Again, all of this could affect and leads to some degree of inability to meet your targets. But in terms of, so the twin problem of stigma and disability, really these are things that can commonly affect children, patients with sickle cell disease. And we know that Nigeria by far is the leading country with the largest number of patients. So for example, like in the UK, we have about 14,000 patients living with sickle cell disease. And the US, there are about 100,000 patients living with sickle cell disease. But in Nigeria, there are 150,000 babies born with sickle cell disease every year. So you can just see the magnitude of the problem and really how do we address this problem. And then so when you think about sickle cell disease, for example, you think about it's not like all one size fit all. People have different patterns of presentation. Even though even some of them that actually have a lower hemoglobin, which is the hallmark of sickle cell disease, actually may not have as many, may have less symptoms than those who have lower, or those who are lower may actually have more symptoms than those who have higher. There are a number of other factors that actually influence this clinical presentation. And one of this is actually trying for the parents and the family to know exactly that this child has sickle cell disease, what is it that they can do to actually kind of prevent this. And some of the things that the children inherit, for example, like fetal hemoglobin, or you refer to as baby blood, if they have a higher amount of fetal blood, that actually will try to improve their outcomes. But one of the major problems that would happen in sickle cell disease, the most common feature, which everybody seems to know, is pain. Pain is actually basically the classical feature of sickle cell disease, and patient will present with that. And unfortunately, some people will say, okay, they just presented with pain, but actually, believe it or not, that is the most key, one of the key features, and we cannot really run away from doing it. And how do we address these problems? There is both acute treatment and prevention. And so, if you know what to do for your patients, then actually you can address some of these issues. And what are some of the barriers that we encounter in actually making sure that patients have access to treatment, patients understand what to do, and these problems that are different in low resource countries, but are different also in high income countries. So you think about a baby that is born with sickle cell disease in the most deprived part of London, the UK, about 99% of them would actually grow to be adults. And that's not the same thing back in Africa, whereby about 50% actually may not survive beyond the 10 years, but we can do something about that. And we can do something by introducing newborn screening and also kind of follow that with effective treatment. Penicillin prophylaxis is one of the key things, but because we live in a high malaria environment, malaria prevention is very important. It don't necessarily have to be drug therapy, but actually the use of treated bed nets, and also making sure that these patients actually have access to it, rather than just giving the net to somebody else, but giving it to the patient that has sickle cell disease. We also know that sickle cell and newborn screening is actually very effective. It's cost effective. If you do introduce it, you actually would reduce the cost of care. This has been extensively assessed and it's shown that we can do something about it. One of the challenges, how do you implement newborn screening in a setting? We have tried since 2009 to 2011. We did a pilot in Abuja, Kaduna State, and Katsina State. And actually, working with the Katsina State government, we led to the establishment of a kind of a clinic that actually had over 20,000 patients. But that service has not been sustainable because it has not been continued. And one of the challenges is that how do we get a system that is established in a state to proceed from one government to the next government without kind of this being kind of truncated, without this being seen as if it is the governor's kind of agenda. This is agenda for our people. And we want to work with states. So we are currently working with Kaduna State and also working with Niger State to make sure that we can implement a newborn screening that is effective. But actually, we do have funding from the European Union. We have funding also support from the US and from some other partners, and even including some of our fellowship in Nigeria, and also the Medical Association of Nigerian Specialists in the UK as well. So we want to work with all of these partners to make sure that these programs are actually implemented in a way that is cost effective. So if you think about the testing of a newborn baby, it's not just a lab test. The lab test is important, but it's actually just the beginning of various things. So I want to make sure that the person actually get access to treatment, gets penicillin prophylaxis, get malaria prevention, and actually they understand exactly what it takes to do when the weather is hot, when the weather is cold, make sure that they take kind of fluid therapies and everything. So these are the things that are actually very key. But actually we need data. We need data to kind of convince the government that you have this number of patients. We just did some kind of a survey in Kaduna State right now, and we have found that actually less than 10% of those sickle cell patients, based on the DHS information, are actually registered with clinics. So where is the 90%, the rest of the 90%? What can we do to actually find out where those 90% are? And actually, how do we actually follow them up and find out the outcome about what is it that actually can be done to them? So it's important to actually know what happens from birth, following diagnosis, and to growth, and to adulthood. And so that services actually can be established. But this cannot be done just by government. It has to be done in conjunction with government. And you understand the challenges kind of to drive something through government. It takes time, it takes a lot of bureaucracy, and really sometimes you reach the point that you want to just give up and actually do something yourself and just kind of run it. But actually, it's important to actually get the government, and that is why it was good for us to actually work with the government to make sure that these programs are actually sustainable. So there are so many barriers, and these barriers actually could be education. These barriers may be kind of really the fact that that is the issue of stigma. So we know that are different stigma in different tribes. The Yoruba have their own term, the Igbo have their own term for sickle cell disease. I mean, you die and you come back, you die, you come back. Or really kind of seeing that, okay, maybe somebody married the third wife, and then the third wife brings children with sickle cell disease, and they say, oh, this is an evil woman that has really come to this family. And believe it or not, a number of families parents have been driven from their family, from their home, because they have a child with sickle cell disease. And like Dr. Kofi Anie said, sometimes these problems are actually attributed to the mother. So when it's something is very good, the father is accepted. But if it is something that is bad, then they actually attribute to the mother. And I have found mothers actually very key in the management that I do in the United Kingdom. And also I found mothers very key in dealing with services and centers in Nigeria. And I think it's important to continue to strengthen the girl child so that actually we have long-term education. So these are some of the summaries, and I just thank you, Nadine. So I'll hand over to my friend, Dr. Makusidi.
Thank you, Dr. Inusa. We heard a lot of things like newborn screening, use of distribution of nets for beds to the right people, the needy, partnership, less than 10% registration in some states, a lot of governmental bureaucracy. So, Dr. Makusidi, you are in charge of the health system in Niger State. So, how has your state fared on the topic of special needs and its associated stigma? And most importantly, please, can you speak on some of the comments made by Dr. Inusa in terms of partnership?
Yeah, thank you very much. And again, I want to thank Nadine and everybody that has organized this program. And a special thanks to Ajia Gimba, my sister, for all that she has been doing and setting up her organization. And most importantly, I must thank Dr. Inusa for finding us worthy to have something to start, at least a baseline of a structure in place to take care of this kind of situation. As you know, Niger State was created in 1976 and situated in north central part of the country. It has over 6 million people with diverse socio-cultural background. So definitely, like the previous speakers have highlighted, we are not exceptional from the challenges of people with disabilities, because we have a lot of socio-cultural background in the state, just like Dr. Inusa and other co-speakers have pointed out. There is a poor health education among the populace, coupled with a lot of poverty. So this has actually hindered rapid progression in attending to some of these challenges. You see that I pointed out the issue of governance, and I categorically wrote non-existing policy or legal framework. For us in Nigeria, we are very good at planning, bringing out theoretical statements, even laws. I don't know whether there is any country that is lawlessness like our own country. Our country is like heaven, where you do everything and you go scot-free. So even if there are laws, for instance, the issue of law for disability people that has been passed as far back as almost 3-4 years, it's not been fully implemented. It's not been fully implemented. It's not only restricted to this, including other laws that have been put in place. You look at the traffic laws in the country, nobody obeys those. I don't know what is happening in other states, but in my own state, nobody obeys them. Now, for the health sector, we really have a lot of gaps related to people with disability and even a general health status. You can see that somebody posted a question that the whole health sector of Nigeria need overhauling. Sincerely speaking, there is a lot of decay. There's a lot of gaps that needed to be fulfilled. So for us in Niger State, we are not exceptional. We are working hard to see that we can revitalize the system. And just like somebody pointed out, the primary healthcare system has so been neglected in the past, where all this kind of preventive measures should be put in place have been neglected. So for us in Niger State, we are focusing on 3 priority areas to make sure that we revitalize the primary healthcare system so that we get all the preventive measures being tackled from the nooks and corners. We should note that Niger State is the largest landmass in Nigeria, constituting about 10% of Nigeria's landmass. We have a lot of hard-to-reach areas. So this, coupled with the paucity of health education, has compounded our situation. Irrespective of the situation, the government of the day is so passionate about healthcare system, and I don't think we've ever been fortunate like this time around, where the governor himself and the first lady of the state is also a consultant gynecologist. In fact, the link to Dr. Inusa's organization was through Her Excellency, and we're about moving forward to establish sickle cell pre-treatment or preventive measures in the states. So we before now have special schools being established in the state to take care of these handicapped people. We have the one in Mina, we have also in Bida, and then of course some other organizations like the Haji Gimbat's own. And then there are associations, for instance, spinal cord injury patients, sickle cell disease patients, and so on and so forth. And of course, in the recent time, the Christian Association or Christian religion groups, you can't marry without the couple undergoing some screening tests, which before now is not in existence. But then other groups are also coming on board. The Muslim group have also proposed in the recent time that this law, even if it's being passed earlier, must be implemented. So we are also reassessing the need to repeal the former one and then to reassess and see how we can implement these laws properly. Now, in the recent time, public buildings have also been structured in such a way that people with disability should also have good access to this building environment. We are about to establish what we call contributory health scheme. That is the social insurance scheme of the state, in which case vulnerable group have been identified. And among these vulnerable groups include people with disabilities, sicklers, and the rest have been taken into consideration to benefit from this special package. In terms of recruitment and engagement in the services, believe you me, we still face a lot of challenges. I am an ENT surgeon. I deal with patients that have what I call hidden handicap, because unlike blindness, polio, and the rest, somebody with hearing loss, unless those that are close relations, do not know that this guy is actually suffering from hearing loss. So I have a lot of them that could not have gainful appointment just because of their disability. Unfortunately, nothing could be done because of the system we are running. And in this respect, when we came on board, we tried to put in place the issue of governance, the political will from the government angle to ensure that these people, they are also human beings. They should be given all the consideration that will be given to normal people. This legal framework should be implemented. And if there is any amendment that is needed, it should be done as soon as possible. Just like Dr. Inusa pointed out, that when government programs or projects are to come in place, they suffer a lot of bureaucracies and you get frustrated. The reason is not far-fetched, it's issue of funding. I'm very sure all of you know that the funding for health in African and especially in Nigeria, I'm sorry to say that it's nothing to write home about, but I hope that in the nearby future, we should get it right. No state, as I'm telling you, has reached the 15% Abuja declaration, talk less of even access to whatever is being budgeted for. So for us, we think there is need for continuous advocacy, partnership, and especially engaging NGOs, because for Nigeria, we believe until a third party comes in, that is when things work for you. And for us in Niger State, we have explored that platform and we're getting it right because we have a lot of partners in the health sector. And believe you me, we've done tremendously. We've been score high among other MDAs in the state. So far so good. This is what we're doing at the health sector to see that we move to the next step, especially as regard to people with disability. Thank you.
Thank you very much, Dr. Makusidi. So we're just going to pause and take some questions from the participants. So our first question, which is something that you've touched on, and I see Dr. Inusa has shared the link. So we have an attendee who asked, does any one of the panelists know if the Nigerian Disability Act has been applied in any situation, in the legal court or social welfare department? Mrs. Gimbat or Dr. Makusidi, are you aware of the actual implementation of that act?
Hello.
Yes, sir, we can hear you.
Yes, I have mentioned earlier the issue of implementation of the acts that have been passed by the Nigerian legislative and then the government, of course. To my knowledge, sincerely speaking, I won't say yes, I won't say no, but to a large extent, I would say no, not being implemented. Because I told you experiences in Niger State. We have people with disability, issue of gainful employment, just like the counterparts and normal people. The only thing I think we've been able to achieve is to have a special places for them for training, which to me is not enough.
Okay, thank you. Mrs. Gimbat, this question came from one of the panelists. Can you, the attendees, can you throw more light on training for parents, timeline, cost? You went to Enugu, you went to the UK, and today you run the Farid Center. Do you have
She's in Niger State.
And she's in Niger State, yes, in Mina. Yes. So can you provide that answer to one of the attendees? I mean, what does it cost for you to train parents? Do you have any specific training for them that they can participate in? And then, you know, in all your journey, I'm sure you have incurred some cost, just to give them that perspective. Sorry, Ma, you're muted.
Oh, sorry. Thank you very much. I'm sorry. Special needs is not just one dimensional. So I cannot just say you're going to use 5 naira or you're going to use 10 naira. You see, special needs is in different, it comes in different fields. You have behavioral under special needs, and that is those with Asperger's, those with attention deficit disorders. Let me tell you about attention deficit disorders, especially as relating to us here in Nigeria, where you find the child is so hyper mostly, and you just say, oh, that child is, you know, he's too hyper, he's not hearing, you know, they hear. They don't know that there are some underlying issues that should be addressed right from beginning. So you see, that's on that aspect, the behavioral. You have those that have autism. The autistic children, especially here, you find out that they say they are being attacked by spirits. Most special needs anyway are being attacked by spirits in Nigeria. They hardly ever want to relate it to a brain problem, a brain damage, starvation of oxygen to the brain, which causes, you know, when you have a stroke victim, someone has had an accident, and just like Dr. Inyang said, special needs you can be a special needs person at any stage in life. It doesn't have to be from birth. You know, some accident victims, sometimes when they have all the complications, it results into them not being able to use most of the assets that they had before. So you see, you have the autistic children. You have Down syndrome children who are most loving. I don't know. They are the most giving, they are the most loving, they are very neat, they are very particular about some certain things. And then you have the CP children, just like my son, with cerebral palsy is in different categories as well. There is, you know, there's a level of severity. Some can be very minor, some can be to the extent that maybe they are walking. My son at 19 is still not able to walk, but he's crawling now. You know, when he's crawling, other children will come in and they are like, how can a big person be crawling? They're expecting him to be walking. So and then some it just affects their speech, is slurred. So I cannot tell you, keep aside 10,000 naira. The first thing I do anyway at my center, is to counsel both parents. I don't see just one parent initially. I try as much as I can. I say, I want the two parents. Here we have the cultural effects of, you find out that it's only the mothers. The mothers always come forward more. The fathers, you don't. So I insist I want to see the fathers. Even if you are the man, you are a man and you are drawing that rosaries that is like 1,000. I want to see you. I don't mind, I'll wear my veil that time, I will see you, but I want to see you that initial time. And then I counsel, okay, this is what I'm expecting from you. What do I expect from you initially? I'm going to assess your child. I'm not the one that does it personally because I'm not a medical personnel, or I'm not a psychologist or a child psychologist. So I do ask them if they have any medical report. Have they been to this place? Have they ascertained what is wrong with that child? Then I ask them, are you willing to be part of the therapy that we are going to offer? Because when you offer therapy in centers, and you want to do it just with the therapist alone, the children go back home. What do parents do with them? You understand? So we always try to tell them at every 3-week mark, or at every 6-week mark, normally we sit with them and we want to agree upon this with them. It's either you're taking the 6 weeks mark or you are taking the monthly mark. We want to sit down with you. This is what you will do when the child comes home, even if it's for 5 minutes. That doesn't cost anything. It only costs you your time, and time is precious. What do you give your children? You give them your precious time. So you do that. Then ordinarily, special needs things that you use for special needs, like speech, the voice machines, the therapy equipment, they are very expensive. The first walker I ever got for my son, when we had the price at that time, we were like, but you know, we braced up and we bought it, and it was very expensive. You bring it back here and they have a way of mishandling it. So what we have tried to do, and what like Dr. Ebibo taught me in Enugu, is to see within the environment what can be used to replace either that patented, because mostly what you get out of this country is patented, and so you can't replicate. But we try as much as we can. Our carpenters, our woodwork, they are very, very good. So we are able to replicate some of this, even if it's not fashioned according to how the original one is, and we make use of it. And you find out that we make do. So it depends on the area you are coming from. I'm privileged, and I always try as much as I can to say, because I'm privileged, I'm able to afford to do some certain things. Not all parents are privileged. And you know, most of these children who are not being brought out are part of those parents who are not privileged in society. So we make do with what we are able to get in the environment, in the society, and we shift. Even taking them out on a walk and showing them about the trees you find in the environment, which is what we do every Friday. You show them things about how to cross the road. It doesn't cost a thing, it costs you just your time, and it costs some volunteers to be able to volunteer to hold the hand of that child and give that child confidence that he can do it. So that's it, basically, if I have to talk about cost. Cost is all about what you can bring together.
Thank you so much. Our next question is from Foinshola Oyebola, and I would like Dr. Takon to respond to that question. And the question is, how does inclusive education work in the United Kingdom? And maybe if you could also shed more lights for the other participants to understand what is inclusive education for special needs.
So inclusive education, so it's when you're trying to educate a child in mainstream education with other children. So children have different levels in which they can be educated depending on the level of severity of their illnesses or cognitive impairment, their functioning. So a lot of children with disability will be educated in the mainstream school. So they're going to the regular schools that other children without disabilities are going to. Now, the difference is that support is funded here. So there is somebody who is assigned to that child. So most children will get a legal framework where the government has said, we'll pay for an assistant for that child. So there's somebody to support that child, help them in going out, help them in communicating, and also support them moving around. But they're learning with their peers because they've had assessments by psychologists who feel that they've got the capacity to learn. So there are lots of children with cerebral palsy who actually are so bright and they can do a lot of things, but people just look at them with their physical aspect and think they can't do things. So the first thing is looking at the functioning of those children. And I've had so many bright children in my clinic or in my population. So they can do all those things, but they need help. Now, children who struggle in the mainstream school even without support, they are then taken to smaller classes, and that's where we have the special schools. So we have special schools for children with moderate learning problems, and children with more severe problems have even severe learning disability schools. So children are structured, but majority of children with learning difficulties or disabilities, physical disabilities, they are in the mainstream school. And so the aim is to make sure that everybody gets learning, interact with peers, whether they've got disability or not, but where it's felt that they can't, then they go to the more specialist schools.
Thank you very much for that answer. We have another question from Adetola John Oge, and she says she has a daughter with autism. How do parents get support, especially when their children are flagged? I think, and her second question is, I am in Lagos. I've been on this journey for 8 years. I actually flagged my daughter. Her diagnosis changed from expressive language disorder to autism after 4 years of ABA intervention. It was a painful ordeal for me. How can this be prevented? Mrs. Gimbat, Dr. Takon, or Dr. Makusidi, or Dr. Inusa, how can this be prevented, and how should parents get support once the child is flagged?
Okay, because I'm not a medical person, I will probably, Dr. Inyang can take that.
Okay. So what I would say is that it's very, obviously in Nigeria, it's difficult because what I've said, early detection is not there. People are not trained to pick these children up, and that's where training needs to come in. It's a big problem. And I've seen children who have struggled. The fortunate ones have been able to come over here and get that assessment done, which is not what we want, because people should not be having to travel and pay so much just to go and get a diagnosis of autism. Exactly. So we need to train people. And again, the support services also involves the schools. It's not just the family getting the diagnosis. So getting a diagnosis is one thing. The intervention for supporting that child in the school, it's about other children in the school understanding the child's needs. It's about all the teachers in the school understanding the child's needs. It's about how to communicate with that child. It's about understanding that when that child is having challenging behavior, they're probably trying to communicate something. So not to go and put that child in a corner. What that child is trying to say something to you, and people don't understand. So it's about training people to know that children with autism present in different ways, but what is that child trying to express? So big training is needed. And I think once we get that right and get all that, everybody working together on the same page, then we can begin to look at other things. But I think early identification, it's so painful. I can completely understand what that. Yeah. Many people go on this for a long time.
We do have a problem. Sorry, I'm interjecting. We do have a problem really about the training you're talking about, because most of those that have special needs education are from this colleges of education. Most universities in Nigeria, I think I can only count like 3, Jos, Ibadan, and Ife. They are the only ones who really, and then there is the Federal College of Education at Oyo that are offering special needs education as a degree. And you know the mentality we have here. If you don't have that university degree, they are not regarding you very much as someone who is an expert to do this. And that's why, because the experts are so few and wide, that's why you have all these diagnoses of, oh, it is ADD, or it is ADHD, or it's Asperger's, because you really need that profession, those professionals to do it. And then what other parents too are on, I don't know her circumstances very much, what she has asked, but I'm sure probably the cost of even trying to find out what is actually wrong with her son initially may have come in, because we have all these professionals and they are so expensive. It's not every parent that can afford it. And that's where we're now talking about support. This support from government. What makes us think we shouldn't include these children in the inclusive education that is being offered in schools? If somebody, when this pandemic started, a parent asked me, he said, they are doing school feeding. What about us that have children? Nobody talked about all the special schools. What they're going, the school feeding thing, he said, if they can feed the children with that, where is the money for these other children? And that's where the Child Rights Act now comes in. Where are the disability acts that we have? How effective? And how do we now start pushing forward? Because I hate talking about yesterday. I want to talk about today and how we can move forward tomorrow. How can we now come together as parents? Because we are the ones that now have to push for our children. They don't have a voice to talk for themselves. We now have to see how we can start pushing all these things that have been written. Can we now start having them one by one, stage by stage, being implemented? We want, like I said, when I had that, the school, we did 9 schools in Niger State, and we were only looking for slow learners, you understand? And we have that, we did that exercise. And you find out that when you find children in school who are so timid and are being bullied, you know, bullying is terrible, and most of these children are being bullied. Those that have all the underlying cases. Well, how do you now start separating them in the school or in the class, not separating them from the other children so that they don't feel as if they are offensive in the class, but now giving them extra attention so that you bring them up to the other children as well. So she may have encountered all that problem. Now the patient, what I will advise her to do is to be a little bit more patient. It's frustrating as a parent of a child with special needs. You want to give that child.
Yes, and I think I will want to advise
Mrs. Gimbat. Let's just hold that thought, Mr. Makusidi, sorry. Let's just hold that thought there for a few seconds. And I'm directing this question to Dr. Anie. Doctor, please, what would your advice be to parents who have children being bullied in school because they are simply misunderstood? They have one special needs or the other. What will your advice be?
Yeah, so I think
listening to us
this is where education, not necessarily education in terms of formal education or whatever we are talking about, education about the conditions. That is the big thing. And I liked the way Dr. Takon talked about the inclusivity of the children in the educational setting. So when you talk about inclusive education, then you can identify those that have difficulties, but they are inclusive so that they don't feel different. Because the whole point about the stigmatization is making them different from others. So instead of trying to isolate them from everybody else, you want to include them. So when it comes to bullying and teasing, for example, sometimes, unfortunately, it will come from their peers, the children, their other pupils in the school, the other students, and so on. But if they understand, in terms of being educated, they are knowledgeable about the condition that is being faced, that would always go a long way. And if you don't separate the child with a disability from the main group of children, that also goes a long way.
Doctor, who should do that education? Is it the responsibility of the teachers or the responsibility of the parents? Should they come to PTA and make those comments?
I think it's a combination of everything. So going from the top, you find out that the educational departments or whoever is responsible for education generally should take some responsibility. The schools can also take some responsibility. But also, I think when you get, let's say parental input. So Mrs. Jimba's work, for example, she can expand it into working with schools and making sure that when the information in terms of the knowledge needs to be acquired within the school setting, when you have people giving their personal stories, that goes a very, very long way to change perceptions. Because most of the time, the perception, the stigma and the perceptions that lead to the stigma are based on, misinformation or myths and misunderstanding.
Okay, thank you very much. Just piggybacking on what the panelists have discussed earlier, if you're out there and you're thinking, I need a job or I don't know what to study at university, please, you have heard very, clearly, we do have a lack in therapists in Nigeria. There are 4 colleges of education where you can go to get trained. And numerous children will be forever grateful for you doing that. So, Dr. Inusa, just bringing the perspective of COVID, the whole pandemic, in your opinion, has the COVID pandemic exacerbated the marginalization of people with special needs and disability? In other words, how has the pandemic affected the special needs community?
So the response to the pandemic for special needs provision in the United Kingdom, as an example, patients who are described as vulnerable, for example, like sickle cell disease, they were shielded and meant that they didn't go out and they provided food for them. But it turned out that towards the end, it became obvious that doing that actually was detrimental to some of their progress. And so it's affected not only their physical risk, but also it has affected the emotional aspect, which is a big challenge. But actually the other way is that some special needs could actually continue during the pandemic because people are aware that it's difficult for parents to actually look after them. And therefore it's important to provide the services during the pandemic period. I think it's really kind of something that needs to be looked at, particularly depending on the institution and the country as well. But I must say that the COVID pandemic has affected service provision. It has, so most of my patients actually don't want to come to the hospital because they are afraid they'll get COVID. And some people actually have kept very sick children. And actually, unfortunately, the outcome has been very bad because they came very late to hospital, and therefore the services that needed to be provided for them wasn't given. So it's multifaceted. But again, there is need to reflect and to see how to respond to it. Thank you very much.
Thank you so much. We are quickly running out of time and we still have a number of questions. So we have a question from Aishatu Gobi, and she's asking, is the electoral process making adequate provision for special needs individuals? How can one influence policies for those who are yet unborn? Dr. Makusidi, I would throw this question.
Well, I'm not a member of INEC, but in the previous elections, I think there was some attempts to meet up with some needs of the handicapped. Well, I pray maybe 2023 election, there should be an improvement, especially the use of a card reader. The blind person, of course, I wouldn't know how they can use card reader without being assisted. And of course, the need is also confidentiality and also to vote for somebody he wanted. So I'm not a member of the electoral body, but I think we should be aspiring to see how disabled people should also participate fully in the country as members of the Nigerian nation.
Thank you very much. We do have another question from Adetola, and she goes, how do we leverage technology to make therapy more accessible and cheaper in Nigeria?
So if I can I answer?
Please go ahead.
Okay. So if I can say that during this COVID period, one of the things that happened to us here was that children could not come and get their therapy in hospitals. The therapists all used a lot of technology in delivering ongoing treatment sessions to families. And it's a case of, lots of people have mobile phones now in Nigeria, and if there's anything that has improved in Africa and in Nigeria is the communication. We can use that. So you have people don't have to travel so far, come from villages, travel hours just to come to a hospital to come and see one therapist who will probably spend 5 minutes with them there because they don't have enough time. People can have therapy sessions delivered through technology,
Telemedicine,
through telemedicine, through telephone and all that. And also, like we've talked about, training people. So even these young people that we're training can also work with delivering some of those sessions through those medicine platforms. And it's something that we need to invest in. A lot of places are beginning to do that, reaching they had to reach in the villages. It's very painful when, I mean, my experience of recently into coming to Nigeria, where I had to see people in the hospital and interact with people. Families were traveling 3 hours, 4 hours, coming to the hospital just to see a therapist, and they would wait so long. And at the end, it was one therapist for so many people. It's not sustainable, and it's not fair on the families. If we think about the fact that they don't have that money, they're investing that money to travel, and they're not really getting what they need to be getting. So we need to think, how are we going to deliver these sessions in a more cost-effective way so that these families can be wherever they are and they can receive those sessions. And Mrs. Gimbat mentioned something, that she works with them in stages, 6 weeks goals, 3 months goals, 3 weeks goals. You can do that. So you teach them something and then you catch up with them again, still using that platform to deliver the therapy services and follow up. So there's a lot we can do. We just need to think about it and invest in it as well.
Thank you very much. We're just running through our final questions. We have a question around how can parents and teachers be educated about the condition of children with ADHD to avoid treating them as though they are being rude. I know one of the panelists, I know Dr. Anie brushed on that, but I don't know, Mrs. Gimbat, is there something that you would like to add? The question is from Samsudin Mohammed. Any of the panelists, yes, please feel free.
Yes, it has already been said that we have special schools or universities in the country that offer programs for the disabled people. So lecturers or teachers are trained from these institutions. And in turn, as we said, it's a collective responsibility of both the parent and the teachers to help the child. So by the time the child is brought to the hospital, though we should also be on the preventive aspects, not the curative, which is the main in the country. Now we're only more on curative instead of preventive. So by the time we're on the curative, it's one responsibility of the teacher and the parent. So the parents will be in turn. Now the teachers will be like they will receive their training. They are now TOT. They now transmit same to the parent, who again will be rendering that services at home, because it's going to be all encompassing, not only facility based, but also community and home based. So the teacher, the parent will now get their training or learning from the teachers or the clinicians or doctors, and then they will in turn now train their own children at home.
Can I just add something that I think that, yes, it's very good for people to go to the universities and everything, but I think you gain a lot from practical experiences. So a center like Mrs. Gimbat's center can be a place to train people. Yeah. What we'll find out is sometimes we're very good with learning the theory, but people lack the practical experiences. If people spend work experience, work placement in a place like Mrs. Gimbat's center, and they learn how to handle the children and work with people, therapies, it's a lot. They would learn a lot more than just going to the school and getting the knowledge from the class. And when they come out, they cannot translate it into practical activities. And also sometimes going to university is expensive, or going to colleges sometimes is so expensive. So we have to have tiers of training people, but practical experiences, encouraging more centers like Mrs. Gimbat's center is so important. And this is what I would say, that we have to look at two-tier approaches.
And I would agree with that, because I think when you talk about training or teaching parents, the practical aspect and the experiences of those who are living with it or going through, again, like Mrs. Gimper's center would give that sort of practical ability to learn how to manage a child or somebody who's affected day to day.
Thank you so much. A final question for Mrs. Gimba. None of the attendees raised that question, but I just feel it might be something worth touching on. Stigma related to special needs within families. So we spoke about practical experience, not just having to go to university. Mrs. Gimba, practically,
Yes.
how would you, what would your advice be to families going through that, especially for those who have just received a diagnosis?
Yes, from my own personal experience, and because my son is, initially he exhibited those signs that are not part of a normal child growing up. That is the missed milestone. I was told to take him to the river and leave him at the river, and that if at all the river spirits take him away, because he is not human. So that's what's coming from a family relation. I've had cause to sit down with a lot of us parents who have said the same thing about their own children being stigmatized like that. I've had cause to be called upon to go and rescue some children that are being locked up, all because the neighbors are not allowing the children to come out to play with either their own siblings or the children within the compound, or with the children within the environment as well. So that it's a terrible thing, actually, and it's really touches on the mental capabilities and stability of not just the mother, but a couple who have a child with special needs. It sometimes leads to breakage of marriages. Either the husband is understanding and the family is telling them you are a fool for accepting that child from that woman, because that woman is either a witch, or that woman has scorned look for trouble with the, what do you call it, the spirits of the night or whatever, and she's the one that has brought this upon. So it results in a lot of heartbreak and heartache. I have a very supportive husband. In fact, he pushes me sometimes to do things which I out of the ordinary. And that's maybe because I've come from that background of having that support. I try as much as I can to tell those that I come into contact with, most parents who I can spend 2 hours with just sitting counseling. And we forget about the children sometimes when I'm discussing about what they have gone through. So it's a huge problem. And counseling is key. Most of our counselors that are being churned out, they don't have much to do right now in Nigeria. And you find out that some of them are even working in banks.
Yeah. I'll just give a quick example to round off. I grew up in Ghana. I grew up with a family, and the siblings, we used to play, we used to go to school together, and for a very long time, I didn't actually know that they had a sister who had autism. It took a very long time. I saw somebody post a comment or a question about hiding the kids away. And this is a typical example, because from the family's point of view and also from the society's point of view, probably at the time, autistic children were not, sort of acknowledged for what they were. So you just hide them away. A child with that kind of disability, you never know. But eventually, and the mother, I would gladly say, eventually had, I don't know what changed everything, but eventually had the support. And then she, in the same way, set up a school for autistic children, which was brilliant as a positive way to end that. just like Mrs. Jimper's story.
Awesome experience. So our final question from the attendees, we have a question from Adenike Aziz. How do we get the government to create more special needs schools in line with the children's needs?
Hello.
What's the question, please?
Hello.
Yes, Dr. Makusidi, we can hear you. The question is, how do we get the government to create more special needs schools in line with the children's needs?
Yes, as I said earlier in my presentation, that there's need for more advocacy and then governance, so to ensure that the government key in or do more from what we are doing currently, presenting memos to the National Council on Health, which is the highest ruling body in any health care decision making in the country. And people with a disability or no disability should be proactive in making sure that this kind of memo is presented to the National Council on Health. I could remember those people with albinism some time ago. They used to attend the National Council on Health and they make presentations related to their issues. So if we can have this kind of advocacy and presentations, I'm sure we'll be far going to the next level.
Thank you so much for that response, Dr. Makusidi. And then final question from us to all the panelists. What will be the key takeaway that you would like our audience to leave with today? So we will start with Dr. Takon.
So I have a lot of hope in Nigeria. I am not pessimistic. I think that Nigeria is a beautiful country. We've got the resources, we've got people who are hardworking, and we just need to be able to have that hope that we don't need big things to change the situation for children with disability. Small things, it's about changing our attitude and mindset. And if we do that and begin to look inwards, Professor Inusa mentioned, we can't all be waiting for government to do things. We've got big organizations, we've got banks, we've got oil companies, we've got lots of institutions. Everybody should put their hands together to say, what can we do in investing to support programs for children with disability? That funding can go towards training, can go towards skilling up people, can go towards developing centers for assessment and diagnosis. A lot of organizations that support children here are actually driven by charity, by individuals who have put down money to actually believe in a cause and doing it. We can do that in Nigeria. We have lots of wealthy people and organizations. We can work together. I believe in Nigeria and I know that we will get it right. So it's hope and it's small changes. It's not perfect here, but people feel ownership towards it and it's about changing the mindset.
Thank you very much, Dr. Takon. Moving to Mrs. Gimbat, your parting words for us.
I'm a mother of a child with special needs. I have 5 kids. My 4 kids, 4 girls, have been wonderful with their brother. See, when you have a family structure, the greatest support comes from family. So maybe my appeal is to us parents to see how we can be together as a family, and the families who are not immediate to be patient enough to have that empathy, to be able to hold on tight to that child with special needs. That child with special needs is just like any other child that you have. I have parents who come to the center and they are paying for so exorbitantly for their children in other places. But what they give here, they give it because they don't have hope that these children will be anybody. So nobody is born useless. Nobody is born without anything that they can give back. It's what you give that you will get. When they see you smile, they will smile back at you. So I will want humanity to prevail within us in the society. I will want humanity to prevail. I want God to touch the heart of our government. we need to have them included in all the decisions that are being taken for the sake of our children. Let's not make them less of our children than they already are. They don't have a voice. We should be their voice, and we should be just by them. Thank you very much.
Thank you very much for that parting remark, Mrs. Gimbat, and we hope any government official listening to us will be the voice for our children. Dr. Makusidi?
Yeah, I'm listening.
Key takeaway from you?
Yeah, the takeaway is that it's not government alone, but it's everybody's business. So we should collectively, what is government? We are the government, everybody. So we should collectively take this as a responsibility and do the needful. So everybody is relevant and not government alone. Thank you.
Thank you. It is our collective responsibility to do something. Dr. Inusa?
So I'll read from a comment on the panel, which is from Bola Ojo. It says there is power in collaborative action and the voice of parents and community, and they are all voters. Collect evidence-based research to underpin your demands from government to help them implement funded provision. And I'll end with 3 E's. 1 is early diagnosis and intervention. And then 2 is education and enlightenment. And then 3, remember your electoral power. I think we're not holding our people to accountability, and that is why they can start with a sickle cell program with 20,000 patients, and then by the time they're ending their office, there are less than 1,000 patients in that service. I think that is needs for accountability. But I agree with all the other aspects about collaboration, and that's what we're working to try to achieve with the current partners that we're working with in Kaduna and Niger State.
Thank you very much, Doctor. And Dr. Anie, closing remark for us.
So my big word is let's accept people with disability. Let's not stigmatize them. The examples have been given. Everybody has a purpose. Let's use our community leaders. Let's use our religious leaders. Let's get the misconceptions, the myths about people with disabilities and special needs. Let's support them. Let's build resilience within families to support them and in the wider society as well. And I think at 60 years, we can use today as a mark to say, going forward, let's take all these points into account and let's see how we can change things in Nigeria.
Thank you very much. Together we can. A huge thank you to all our panelists for taking the time to be with us today and, on this very important topic on breaking down the stigma around special needs and disability in our country today. We thank you for all that you do in your various capacities to raise awareness and building a more inclusive Nigeria. Thank you so much. And to our audience, thank you for joining us from your various locations. We have people from pretty much everywhere in the country and outside the country. Thank you for joining us. We hope this session was the most profitable 1 hour for you. It is our dearest wish that wherever you are, in whichever environment you find yourself, you will be challenging the status quo going forward and the stigmatization of people with disabilities. On behalf of the platform Nigeria, thank you once again for joining and happy Independence Day. Thank you.
Can I just take this opportunity to thank Nadine, Tayo, Lawal for an excellent organization and effective leadership. We need this for Nigeria, and thank you and happy anniversary.
Thank you.
Thank you very much. Thank you all.
Bye.
And the conversation continue. We have a hashtag, which is hashtag the platform NG60. So we can continue the conversation there. Thank you all.
Thank you. Bye-bye.